Welcome back everybody, David here again with Med School Bootcamp. So in this next video, we are now going to talk about potassium-sparing diuretics. If you recall from previous videos, we talked about how stuff is filtered through Bowman's capsule. We have PCT, where our carbonic anhydrase inhibitors act. We have the loop of Henle, specifically the ascending loop of Henle, where our loop diuretics act. We have the distal convoluted tubule, specifically the early distal convoluted tubule, where our thiazide diuretics act. And now we finally have a combination of the late distal convoluted tubule and the cortical collecting duct, which I'm highlighting over here, because this is the portion where our potassium-sparing diuretics act. Now, you can probably tell from the name that this type of diuretic, right, this class is kind of unique, because it tells us these are potassium-sparing. This is different than our loop diuretics. This is different than our thiazide diuretics, which we would describe more as potassium wasting. We talked about in both of those, patients can get a hypokalemic state. But in these medications, we can actually develop a hyperkalemic state. So we'll talk much more about that. When we think about the mechanism of action here, we have to consider two specific groups. So our medications are going to include aldosterone antagonists, which are going to be our spironolactone and our eplerenone, and a different group called our ENaC blockers, which stands for our epithelial sodium channels. And this is going to include triamterene and amiloride. So these medications are in the same class of potassium-sparing diuretics because they share a lot of similar properties, but the actual way in which they go about this, the actual mechanism, differs quite a bit. So an aldosterone antagonist, you guessed, inhibits aldosterone's effects. It inhibits the mechanism. So if you draw your attention down here to our diagram, we can see that aldosterone acts on the cells. And aldosterone is actually a steroid hormone that has many effects in the body. And so we talked about this in our nephron transporter section, but aldosterone is a mineral corticoid that can actually enter cells and induce protein synthesis, which has a variety of different findings. One of which is it can actually stimulate the production of the sodium-potassium pump, as well as our epithelial sodium channels and our potassium channels as well. And so if we kind of work backwards from this, if activating aldosterone receptor is going to cause the increase in protein synthesis to increase these channels, well, inhibiting is going to do the opposite. So if we now inhibit with an aldosterone antagonist, what's going to happen to our sodium? Well, we're going to have less stimulation of our sodium-potassium pump. We're going to have less of our sodium channels reabsorbing sodium from the tubules, and we're going to have less of our potassium channels as well. So this explains to us the findings that we see here. We have less sodium reabsorption. We're also going to have decreased potassium excretion. Why is that? Because we have less of our potassium channels, which is going to allow the potassium to go into the tubule. Fewer of these potassium channels are going to allow less of it to pass into the tubule itself, and that's why less of it is excreted from the body. AKA more of it is retained in the serum itself because we do not have the channels that are allowing it to leak into the lumen. And ultimately, as the name implies, this is a diuretic. So we're going to have increased urine output. And this should make sense to us, right? Because if we have less sodium being reabsorbed, what's that going to do to the water status? Well, the same principles are going to continue to apply that we've talked about previously. If we have decreased sodium reabsorption, that means we have more sodium in the tubule itself. And what's water going to do? Well, it's going to be sucked into the tubule, and then ultimately all of it is going to be excreted from the body. It's going to move distally, and because we're already in the late DCT of the collecting duct, there's not that much more room to go. It's likely going to leave the body at this point. So again, I want you to understand the physiology here. I want you to appreciate this. The mechanism explains the physiology. It explains some of the adverse effects that we'll talk about later on as well. Now, the final thing here that should make intuitive sense is that we have decreased proton excretion, and this can lead to a metabolic acidosis. Well, why is that? If you draw your attention more distally, we have a potassium hydrogen ATPase in the system, right? Typically, in a normal kidney, we have potassium being reabsorbed and hydrogen protons being excreted, right? We're pulling back in potassium in the body. However, in potassium-sparing diuretics, we are decreasing our excretion of potassium. Why? Because these potassium channels are not allowing it to leak into the tubule. Well, then what's going to happen in the body? We're going to get a hyperkalemic state, and that's going to stimulate the potassium hydrogen pump. But keep in mind, this pump can actually go either direction. So we're always trying to maintain homeostasis. So in the image right now, we see that potassium is being reabsorbed and hydrogen is being excreted. But if potassium is very high, this will actually reverse. And so now potassium will be excreted, which is going to lead to more hydrogen protons coming back into the body. Again, these pumps are often based on gradients. So depending on where the gradient is, at baseline, we want to bring back the potassium. But if we have too much potassium, this pump will actually do a reversal. And now to try to maintain homeostasis, we're going to be kicking out potassium, which is going to result in reabsorbing more hydrogen protons. And that is one of the reasons why we can get a metabolic acidosis in these patients. Now, moving on to the next one, we have our ENaC blockers. So we'll see inhibition of the ENaC channel, also called the epithelial sodium channel, ENaC for short. We'll get decreased reabsorption of sodium, which should make sense to us, right? This is a channel that brings back sodium. So if we decrease that, or if we inhibit that channel, then it makes sense that less of it is reabsorbed. We will get decreased potassium excretion and we will get increased urine output. Again, this is directly related to the decreased sodium reabsorption. Anytime we have more sodium in the tubule, we're going to increase our urine output because it's going to pull more water. So if we draw our attention to the image again, we see the ENaC channel right here in the principal cell. Well, an ENaC blocker, which inhibits this channel, can intuitively make sense to us why we would have less sodium reabsorption because we block the channel that brings it back. That's going to increase sodium in the tubule, ultimately pulling more water into the tubule as well, which then are both going to be excreted from the body. That's why we get the increased urine output. Now, why do we see the decreased potassium excretion here? Well, there's kind of a multifactorial explanation, but one of the primary ones that we should be familiar with is the fact that the charge gradient is different now. If we're not bringing back sodium, the plus gradient, the positive gradient inside the cell becomes less. And if there's less of a positive charge gradient, less potassium is actually going to get pushed out through this ROMK channel. The ROMK channel stands for the renal outer medullary potassium channel, and it's another type of channel that we see in the principal cell itself. And so again, this is what contributes to this type of medication being considered under the umbrella of a potassium-sparing diuretic. Now, when we move on to our clinical uses here, you'll notice some familiar things from our previous discussion on diuretics, our loop diuretics and our thiazide diuretics. We have our congestive heart failure and our cirrhosis, which are both types of edematous states. This can also be used for hypertension. We've talked about previously how offloading fluid for patients can be useful for their blood pressure. Sometimes we get volume overloaded. This is what causes us to have high blood pressure. We can resolve that by giving them some type of diuretic. It's also important to note for that congestive heart failure, these types of diuretics have a mortality benefit. And the reason is because it can actually decrease cardiac remodeling. And I don't want to get lost in the weeds here as far as the pathophysiology, but essentially giving this medication can actually decrease the amount of stress on the heart. By offloading some of that fluid, it decreases the remodeling, right? We're not dealing with the chronic hypertension anymore. We're not having to have various things happen to the heart, such as hypertrophy. And this has been shown in clinical trials to actually improve patient survival. And so sometimes they will test you on that fact alone for potassium-sparing diuretics. Now, some other medications that also have mortality benefits are going to include things like beta blockers, or ACE inhibitors. So keep in mind, there are several medications that have a mortality benefit for patients. And essentially what that means is it just decreases the risk of cardiac remodeling. And it's been shown in clinical trials to allow patients to have a longer lifespan. Now, one of the unique ones that I want to talk about here is the use of hyperaldosteronism. This should make sense to us intuitively. If a patient has too much aldosterone, or primary hyperaldosteronism, sometimes also called K.A.N syndrome, then they are producing too much aldosterone from their adrenal glands. Well, giving them an aldosterone antagonist, such as spironolactone, can be useful. If we block the receptors, right, the aldosterone doesn't have anywhere to act. So we can have all the aldosterone in the world. If the receptors are blocked, if there's no place for it to bind at the cellular level, then it's not going to be able to have its effects. And that's why sometimes the treatment for hyperaldosteronism is to use one of these potassium-sparing diuretics, specifically the aldosterone antagonist. Now, another clinical use for this is going to be potassium wasting. So remember, patients on loop or thiazide diuretics are predisposed to an adverse effect of hypokalemia. Why is that? Well, just a refresher, sodium is blocked earlier in the nephron, right? So sodium is blocked here, it could be blocked here, it could be blocked here. But then it ends up in the collecting duct. And we've talked about the collecting duct is the final place where sodium can be reabsorbed. But to reabsorb the sodium, it's at the risk of pumping out protons and potassium ions. Because we've done inhibition at the loop of Henle or inhibition at the convoluted tubule with our other medications, our loop and thiazide diuretics, more sodium distally in the collecting duct will be reabsorbed, or at least it'll be attempted to be reabsorbed at the expense of potassium and hydrogen ions. And so this medication, a potassium-sparing diuretic, can be used in combination or in conjunction with those potassium-wasting diuretics. And a lot of times you will see that. A patient who's started on a loop diuretic, whose potassium, say, drops like 2.8 the next day, it's very low, we can then supplement their furosemide or their loop diuretic with a potassium-sparing diuretic. So we'll continue to have an increased urine output for this patient, but now we're balancing the potassium levels. So we're not trading one problem for another. Additionally, one unique clinical use for amiloride is with lithium-induced nephrogenic diabetes insipidus. Remember in the last video we talked about nephrogenic diabetes insipidus has to do with ADH being released normally from the central nervous system, but it's not able to act at the collecting duct itself. Well, one medication that can actually cause nephrogenic diabetes insipidus is lithium. Now, amiloride can actually be used in patients who have specifically lithium-induced nephrogenic diabetes insipidus because amiloride can actually block the entrance of lithium through the sodium channels. Now, moving on to our adverse effects here, we can get hyperkalemia. And again, this one should make sense intuitively. These are potassium-sparing diuretics. Too much of them can cause potassium to elevate too much. This can cause a hyperkalemic state. When we think about our other diuretics, our loop or thiazide diuretics, we talked about how this can cause hypokalemia. So this can be used to actually offset that potassium loss. We can use a potassium sparing with a potassium wasting diuretic to have the optimal results for the patients. Another adverse effect here is going to be anti-adrenergic effects, which is typically going to be seen with spironolactone, although it can also be seen with some other ones as well, including eplerenone. But why? Why does this happen? Recall that aldosterone is a steroid hormone, and so aldosterone antagonists are blocking steroid hormones, but they can also block androgens because they're so similar in their structure and how they look in the body. And because it can block other androgens in the body, this can cause some adverse effects for patients. So it can cause gynecomastia, it can cause amenorrhea, and it can also cause erectile dysfunction. Again, things that block androgens in the body. These aldosterone antagonists, yes, they block aldosterone's effect, but they can also block the effects of other steroid hormones throughout the body. Now, while typically this is an adverse effect, it reminds me of a condition that we can actually use this medication for good. We can use to help a patient who has elevated levels of androgens. Can you think of a situation where a patient might have elevated levels of androgens and they do not want those effects to take place, and so giving one of these medications could be helpful? Well, one of the classic ones is going to be PCOS, which is polycystic ovarian syndrome. Remember, in this condition, patients have significantly elevated levels of androgens, which are causing unwanted side effects. And so in this case, giving a medication that can block some of those androgens would actually be a useful situation. So I'll highlight that in here to keep in mind that this is another important clinical use for these patients. Now, a classic patient presentation for this type of medication can quite frankly be a lot of different things. There's not really a classic presentation here, but one possible example could be a 7-year-old patient who has a known history of congestive heart failure. They present to the emergency department with worsening shortness of breath that's been going on for 2 days. They report that they typically take furosemide on a daily basis to help with their fluid balance level. However, they think they might have taken a double dose in the last couple of days because they've run out of their medication. They report that they've been feeling a little bit weak lately, and in the emergency department, you actually get an EKG of the patient, and you see some T-wave changes. Specifically, you notice U waves on the EKG. And the question asks you, what could be going on with this patient? Which electrolyte derangement is most likely? And the correct answer here would be that this patient likely has hypokalemia. They're on a loop diuretic. They're on a known potassium-wasting medication. They run out of their medication before they expected to, right? They think they might have taken a double dose. Well, that could have dropped their potassium, right? If they took too many doses of their furosemide one day, they forgot and took a double dose, that drops their potassium. That could explain their weakness, right? That can also explain the EKG finding of a U wave. And so the most likely electrolyte abnormality is that this patient has hypokalemia, and that's why they're presenting to the emergency department today. So just a quick summary of this video. There's actually a lot here, so I really want you to go back and watch this if you're unfamiliar with the details, but we're talking about potassium-sparing diuretics. The name tells us a lot about these. These are diuretics. They're meant to offload fluid, right? So there's two different classes. We have aldosterone antagonists and our ENaC blockers, but both of them are going to act to decrease sodium reabsorption and decrease potassium excretion. This makes sense to us. Decreasing sodium reabsorption is going to lead to increased urine output because water follows sodium. Clinical use is going to vary, right? These are often used in patients with heart failure or other edematous states. This can also be used in hyperaldosteronism, specifically the aldosterone blockers, which should make sense to us. And another unique one is going to be our lithium-induced nephrogenic diabetes insipidus, in which we would use the medication amiloride. I point these out to you because these are very unique treatments for various conditions, and thus there's really only one right answer if they present that to you in a test question. Finally, talking about adverse effects here, some of the ones we would expect: hyperkalemia, because they're potassium-sparing diuretics. Taking too much of them can lead to an imbalance in our potassium levels. And finally, we can have adverse effects with anti-adrenergic states. This can cause a variety of different findings patients don't want. Because these anti-aldosterone medications block steroid hormones, they can also block our androgens. This can often lead to symptoms that a patient does not want. However, there are situations this is a positive effect, and we talked about that right here with PCOS.